Hey everyone, I am Dr. Raymond Oliva, the Medical Director for Astellas Philippines. And our speaker for today is the head of the Urogynecology and Incontinence Center of Makati Medical Center. She's also the section head, Urogynecology and Pelvic Reconstructive Surgery at Makati Medical Center. She had her clinical and research fellowship of urogynecology and pelvic reconstructive surgery at the Mount Sinai Hospital of the University of Toronto, Canada in 2004 and 2007. She's also a board member of the Philippine Continence Society. She was selected to receive the 100 Most Influential Filipino Women in the World Award, and she received the Distinguished Alumni Award given by the UERM Memorial Medical Center in 2020 for Innovation and Thought Leader. She also received the Trailblazer Award given by the Da Vinci Surgical System, and which is an award for the outstanding achievement of being the first Filipino surgeon in the Philippines to perform 100 robotic surgeries. So doctors, we are pleased to have our speaker for today, Jennifer Marie B. Jose.
Thank you very much, Astellas, for that very kind introduction. Good afternoon. My role this afternoon is to present to you the role of beta-3 receptor agonist in the management of overactive bladder. The definition of overactive bladder. Urgency is a complaint of a sudden and compelling desire to pass urine, which is difficult to defer. Urgency urinary incontinence is a complaint of involuntary leakage accompanied by or immediately preceded by urgency. Urgency with or without urge incontinence, usually with frequency and nocturia, can be described as overactive bladder syndrome, urge syndrome, or urgency frequency syndrome. Okay. Look at the prevalence of overactive bladder and urinary incontinence. It exists both in men and in women, but the prevalence is higher for women. Okay. This is actually a local study by Dr. Bolong et al., a study on the prevalence of urinary incontinence and other urologic symptoms in the Philippine Multicentral Urological Foundation Research Group. And they found out that in terms of the type of incontinence, stress incontinence comprises 61%, and in terms of the distribution of severity, the incontinence is only mild. The prevalence of urinary incontinence in Asia is about 15%. And look, we have a high Philippine prevalence. 4 to 10% of the adult population, equal in men and women, have urinary incontinence. And in our offices, we have 50% presenting with urgency and urge incontinence. So it's actually very high. Look at the OAB symptom perception by gender. The percentages are actually weighted. Urinary problems like something you have to learn to live with, and also it is a natural part of aging. Majority of patients think that overactive bladder is actually a natural part of aging. And because of this, they do not consult. I think it is important now that we have to educate our patient that we can actually improve the quality of life by treating overactive bladder. So how do we diagnose overactive bladder? Of course, we have to do a complete history and physical examination. We always have to do a diagnostic test like urinalysis, and if there is infection, we have to treat. It is actually very important that we educate our patient with regards to the normal urinary tract and what are the benefits and also the risk of treatments. And once we are able to explain everything to our patient, they have to be engaged in the treatment, both for behavioral treatments and also for the pharmacologic treatment, so that we can achieve our treatment goal, which is to improve the quality of life of patients. If the patients still do not improve, then we have to make them come back and see us. Why? Because first, we have to explain to them, number one, what are the side effects? When do we expect treatment? How will we have to change the medication, or how do we need to add another medication so that we can achieve our treatment goals? Okay. So these are actually our tools. We have a 3-day voiding diary. What do we put in our 3-day voiding diary? We put there what we drink. Is it coffee, tea, milk, or juice? We indicate the time that we have to take these fluids and also the amount. So aside from the input, we also have to measure the output. We have to mention the time and also the voided volume, and also what are the accompanying symptoms. With this, we can actually deduce a lot, because number one, if you have overactive bladder, usually the volume voided is usually less than 100 milliliters. Another tool, we have the OAB symptom questionnaire. Here we have all the symptoms of overactive bladder, and we have the urgency incontinence, frequency, and also nocturia. What is the most important symptom here? It's actually urgency, because if we don't have urgency, then we're not talking about overactive bladder. Okay, so why do we need to treat overactive bladder? Overactive bladder symptoms impact quality of life regardless of continence. So 92% of patients report a health-related quality of life reduction following onset of the OAB symptoms. And this quality of life is affected regardless of whether OAB patients have continence. Okay. And this will actually result in anxiety. Look at this study. It says here that anxiety was moderate to severe in 24% of patients. Okay. In addition, we have psychosocial measures in overactive bladder patients and age-match related controls. And we can see that the sleep is actually disrupted. Patients would feel fatigue. We have somatic symptoms, psychological stress, and even depression. Okay. So approximately half of our patients believe that OAB symptoms are a normal part of aging. Many patients believe their overactive bladder symptoms will actually worsen over time. These perceptions can result in considerable delays in patients seeking medical help for their symptoms. So how do we manage overactive bladder? Okay. The first thing that we need to do is actually lifestyle changes, okay? So how do we advise our patient? First, we have to lose weight, reduce caffeine intake, limit fluid intake. We have to stop smoking. We should have a regular voiding schedule, address constipation, pelvic floor muscle training and bladder training, and also optimize treatment for comorbidities. For pharmacologic treatment, the European Association of Urology has guidelines in 2018, which also is the same as the guidelines presented now in 2021. Look at the antimuscarinic agents. In terms of adherence and persistence, look at the summary of evidence. First, we have adherence to antimuscarinic treatment is low and decreases over time because of lack of efficacy, adverse events, and also cost. Most patients will stop antimuscarinic agents within the first 3 months. Now, with the advent of this beta-3 agonist, we have mirabegron. Look at the recommendation. We have a strong rating because this is good to offer antimuscarinic drugs or mirabegron to adults with urge urinary incontinence who failed conservative treatment. Okay. So beta-3 agonist in the management of overactive bladder. This is actually a very important slide. The one on the left will actually deal with antimuscarinic medication, and the one on the right will deal with the beta agonist drug mirabegron. Let's start with the left. The antimuscarinic drug actually blocks the receptors of the acetylcholine receptor, and therefore, what happens with the bladder? There is involuntary inhibitory contraction. This is actually very different from mirabegron because the mirabegron has no effect on parasympathetic stimulation of the detrusor contraction and bladder emptying. And therefore, because of the mirabegron, what happens is that it will increase relaxation and therefore increase storage capacity and also intervoid interval. Okay. So again, look at the EAU guidelines. Okay, look at the summary of evidence and recommendations for mirabegron. It shows that mirabegron is better than placebo and as efficacious as antimuscarinics for the improvement of urge urinary incontinence symptoms. Adverse event rates with mirabegron are similar to placebo. Patients inadequately treated with solifenacin 5 milligrams may benefit more from the addition of mirabegron than dose escalation of solifenacin. Look at the recommendation to offer antimuscarinic drugs or mirabegron to adults with urge urinary incontinence who failed conservative treatment. In addition, look at the summary of evidence and additional recommendations for the use of antimuscarinic drugs in the elderly. Antimuscarinic drugs are effective in elderly patients. Mirabegron has been shown to be efficacious and safe in elderly patients. In older people, the cognitive impact of drugs, which have anticholinergic effects, is cumulative and increases with the length of exposure. Oxybutynin may worsen cognitive function in elderly patients. Solifenacin, darifenacin, fesoterodine, and trospium have been shown not to cause cognitive dysfunction in elderly people in short-term studies. Look at the recommendation. Long-term antimuscarinic treatment should be used with caution in elderly patients, especially those who are at risk or have cognitive dysfunction. And this recommendation is actually strong. Look at this slide, mirabegron in OAB. We can see here that the frequency actually decreases in 24 hours, right? And this is good for mirabegron 25 milligram, 50 milligram, and 100 milligrams. And this occurs starting at week 4 of treatment. So 4, 8, and 12, you can see that the frequency is actually reduced. In addition, we can also see that same pattern for urge urinary incontinence episodes in 24 hours. Okay. Look at this slide. Look at the secondary endpoints. Because of the decrease in urinary frequency, what happens is that the mean volume of voiding is actually increased. The volume of urine is actually increased. The level of urgency is actually reduced. The number of urgency episodes are actually reduced, and the number of urgency incontinence are also reduced. Okay. Look at the mirabegron in OAB adverse events. Okay. What do we see here? We can see here that among the different kinds of medication, we have the mirabegron, we have the antimuscarinic therapy, and also teltoridine. The adverse effects significantly higher with teltoridine ER versus placebo were constipation, dry mouth, blurred vision, and fatigue. The adverse effects significantly higher with other antimuscarinic agents versus placebo include erythema, hyperhidrosis, pruritus, and urinary retention. So the least among this least side effect among all this medication is actually mirabegron. Okay. Look at the OAB persistence of treatment. Because of the least side effect, majority of the patients would actually continue in their treatment with mirabegron, and they get very good outcomes. Okay. So look at the cardiovascular safety of mirabegron. This is actually a study in a 12-week population, and they actually monitor the systolic blood pressure and the diastolic blood pressure. And look, they've noted that the systolic blood pressure, the baseline is actually maintained at 120s, and for the diastolic blood pressure, it's actually at 70s. Okay. Now, this study shows that beta-3 receptor agonist prevents cardiac dysfunction with the use of neuronal nitric oxide synthetase. So actually, with the intake of mirabegron, it is actually cardioprotective. We also have the latest BELIEVE study. It is a European real-world study of mirabegron in overactive bladder. We have a 12-month prospective non-interventional study, and this is conducted in 8 European countries in patients with overactive bladder who were prescribed mirabegron in clinical practice. So the patients involved are adults with overactive bladder symptoms, and 74% were females, 48% were more than 65 years, and 42% were treatment naive. And look at the primary objective, change from baseline in quality of life based on OAB question scales. Okay. And what do we see here? The quality of life improvements were observed from baseline in patients less than 65 years and those above 65 years of age. And persistence is 53.8%. Of patients were still receiving mirabegron even at 10 to 12 months. So actually, they are continuing the treatment. So for the BELIEVE study, the adverse effects were consistent with the known tolerability profile of the mirabegron. And look at the real-world data. Mirabegron has demonstrated improved persistence compared with antimuscarinics, right? So you can see that the patients would actually continue the treatment continuously, and they because they have less side effect and they get good outcomes. Okay. So what we have learned today, this is actually very short, but I think what is important here when we do history taking is patient-centered communication techniques, facilitate understanding of each patient's unique perspective on OAB, and then we have to take our patients to be engaged in the management. We have to agree in realistic goals, to consider symptom burden, adaptive behaviors, and desired treatment outcome is actually the key for good result. And mirabegron demonstrated clinically meaningful improvement in terms of quality of life of patients, which is the target, right? Regardless of age, more than 65 or less than 65, in the real-world BELIEVE study, and OAB treatment should be tailored to each individual. Considerations include comorbidities and concomitant medications, anticholinergic load. So we can actually combine anticholinergic and also beta-adrenergic medications in the treatment of overactive bladder. Thank you.